Hello everyone. Today let's learn about another important topic named Galeazzi fracture. So let's see what happens in Galeazzi fracture. So this is an X-ray showing fracture present at the distal 1/3 shaft of the radius as well as distal radioulnar joint. This is the distal radioulnar joint. So this is also involved. So this fracture is known as Galeazzi fracture. So in Galeazzi fracture you can see that there is distal 1/3 radius shaft fracture plus distal radioulnar joint dislocation or subluxation. Diagnosis can be made through X-rays. In the AP view, you can see that distal 1/3 radius fracture along with this widening of the distal radioulnar joint is seen in AP view. In the lateral view, you can see that there is dorsal or volar subluxation of the distal radioulnar joint. Next, let's learn about incidence of DRUJ stability. Distance of the radius from the articular surface has to be seen. If the fracture is less than 7.5 centimeters away from the articular surface, then the chances of DRUJ instability is more than 55%. If the fracture is more than 7.5 centimeters away from the articular surface, then this indicates that the chances of DRUJ instability is less than 5%. Okay, so the distal radioulnar joint is more stable in supination. Clinical features. Patient comes to you with complaints of pain, swelling and deformity. On examining the patient, you can see that there is tenderness present at the fracture site. You have to also check the range of movements. Both supination and pronation movements of forearm has to be checked. And these are the few important signs which indicate DRUJ instability. So this indicates ulnar styloid fracture, widening of the distal radioulnar joint can be seen on AP view. Either dorsal subluxation or volar subluxation is seen on the lateral view, and significant radial shortening like more than 5 mm indicates DRUJ instability. Based on this, next comes is the treatment options. So the treatment options include open reduction and internal fixation. First, initially the radius shaft of the radius has to be fixed. After fixation of the radius shaft, then we have to think about reduction and stabilization of the distal radioulnar joint. One method is through dorsal capsulotomy, or the second thing is if you have to see whether the distal radioulnar joint is stable or no. If the distal radioulnar joint is stable, then you can do cast immobilization, keeping the patient's hand in supination for 6 weeks. If the distal radioulnar joint is unstable, then you have to see whether it is reducible or no. If it is reducible, then reduce and pass percutaneous K wires and leave the pins in place for 4 to 6 weeks. If the distal radioulnar joint is not reducible or if it is blocked, then you can go for open surgical release. Then comes as complications. One of the complications can be compartment syndrome, non-union, neurovascular injury, malunion, chances of refracture also is there, and distal radioulnar joint subluxation. I hope you like the video. Enjoy. Take care. Bye-bye.